It's time to get endocrinologist perspective on today's topic, which is the calcium conundrum. Let me introduce Dr. Raj Bhattacharya. He is a board-certified endocrinologist at the University of Kansas Medical Center Hospital, and also he's an assistant professor in the Department of Internal Medicine. He is interested in several research topics like areas osteoporosis, endocrine diseases, vitamin D deficiency, then disease states, health, etc. So Dr. Bhattacharya has served as PI, and he's on as PI as well as co-PI on several phase 1, phase 3, and phase 4 clinical trials. And he is also an ad hoc member for the Professional Practice Committee of ASBMR, which is American Society of Bone Mineral Research, which actually formulates guidelines for osteoporosis for North America. So today, it's our pleasure to have Dr. Bhattacharya and have his input as an endocrinologist on this topic. Please join me in welcoming Dr. Bhattacharya.
I have a recent knee injury, so I have to sit, unfortunately. Actually, I'm very glad that Dr. Essick discussed first before I came, because a lot of the work, it actually goes really well together. So we'll discuss the current issue that has arisen, which was the calcium-induced cardiovascular disease, and the significant problems that can occur, and then some potential solutions for your patients who are asking questions. And we can discuss that. And then what happens is, before I forget, I'll email Adrian Baxter the recommendations from ACE, the American Association of Clinical Endocrinologists. And then if you would like to get those recommendations, please email her and she will send it to you for your patients on that website. So anyways, I like to start these talks with a joke. I think that it's a good way of starting, especially since we have one lecture. So I like this one. So a guy comes to his doctor. Doctor says, I have some bad news and I have some worse news. And the guy goes, okay, all right, well tell me what it is. And the doctor goes, well, unfortunately, you're going to die in 24 hours. And the guy's like, that's the bad news? Like, how could there be any worse news? And the doctor goes, well, I kind of forgot to call you yesterday. So with that, we're going to start. I wish I had a little bit more graphics, but unfortunately I had some time deadlines. The big concern, alarmist issue that arose was from this article. This is the British Medical Journal Boland article, which is Boland, and I have to say Reed. Ian Reed is the main principal individual. And we're going to discuss this article, but I'm going to focus on the weaknesses. And one of the best parts is, since Dr. Fossick is here, it's kind of like a prelude to the understanding of this. So this was an article that was based out of Australia, but they basically did a meta-analysis. And meta-analysis in research is like metaphysics in physics. There's a lot of problems with meta-analyses. So what they looked at was studies that were randomized controlled trials that had calcium only, and had 100 more patients that were over 40 years old. Duration of those more than 1 year. That in itself is a weakness. But they had 15 studies with 12,000 patients. 5 studies contributed to patient-level data. Only 5. 6 were just reading it like anybody else would read it. And 4 of the studies had no CV events published. The endpoints that they were looking at, primary endpoints, was first time to MI, first time to CVAs, and then a composite endpoint, which is commonly used. It's also called in cardiovascular literature, I'm not a cardiologist, but MACE, major adverse cardiovascular endpoints. And the secondary endpoints was time to death, all-cause mortality. Try to break it out as easy as I could. So this is the results, but before we go to the results, there's a fundamental thing that when you analyze or look at any study at all, and that is looking at the background comparisons of the individual patients in the different subgroups. In this subgroup, it is calcium versus placebo. So what happened is what Dr. Bostic brought up, that there are specific risk factors for cardiovascular disease. Previous history of cardiovascular problems, current medications such as statins, which are very important and very well used, history of diabetes, history of hypertension, and now multiple other cardiovascular risk factors. Those are just the beginning. Those are just at the medical student level. Well, what happened was overwhelming majority of these trials were not randomized toward those risk stratifications, period. And if they are not randomized to risk stratifications, is it the drug that's being given, or is the background characteristics of the individual patients? And unfortunately, you will see this, that in medicine, what we do is I guess the Midwest we call silos, or in other places we call other things, but we silo out places. So people in the calcium osteoporosis world don't talk to the people in the cardiovascular world who don't talk to the oncologist, and we have our own things. Those people who do osteoporosis research don't take care of diabetics or hypertension, or don't have a fundamental understanding of that. So that is the prelude, and this is the understanding. And let me see if I can go over here, or we could do it on the pointer if people can't see this. So what they showed at the end of this meta-analysis was that in the calcium group, there was a slightly statistically increased rates of MIs, of heart attacks, in this group versus placebo. There was not statistically significant CVAs, or even an all-point was not statistically significant. In death, there was no significance. And actually, the placebo group had a lower number of death. So what they said was, hey, there's an increased rate of MIs in people with calcium by 1.27. And therefore, the calcium supplementation increases with 30% the incidence of MIs. Again, it's not that simple. None of the trials had CV endpoints as their primary endpoint of data, and none of them gathered them in a standardized measure. It's kind of like if you're doing a dietary questionnaire and someone says that they're drinking milk and you don't know if they're drinking 4 ounces or 12, that makes a big difference. And then there was a significant amount of incomplete or no data in the cardiovascular endpoints in 7 trials. This is the breakdown of these trials. It projected much easier than I expected it to, so I'm very happy. So one of the other fundamental problems was the author, Dr. Reed, and Ballard, the other guy, based a lot of his evidence on his own trials that he previously published. Then, if you look at again, and looking at cardiovascular risks, again, they were not discussed, they were not placed. In the Riggs article, there was no data. There's simply no data that is in here about their baseline characteristics of these individuals. Further on, these were more data in a treatment allocations that break up into MI, strokes, composite, and death, and an MI, strokes, composite, death. Well, what you do in a randomized controlled trial, in a large multi-center trial, what happens is that you adjudicate these risks by having two different groups of healthcare providers looking over the MI criteria, looking over the stroke criteria. And that was not done in many of these trials, if not all of them. But here is the tale of the tape. Now, I brought this up to other cardiologists, and I discussed this with Dr. Vasek. So here's the fundamental issue. The separation of the curves occurred right away. Look at this. Look, you have reduction in the placebo. You have reduction in the placebo group, or increase in the MIs in the calcium group right in the beginning. So is it the drug that's doing it? Or is it the pre-existing conditions of the baseline characteristics of the patients? And that is my fundamental problem that I have with this problem. And again, Dr. Reed stressed his own work. So we're going to talk about Dr. Reed's work. So his main study was this older woman study, length about 5 years. And, and then what he looked at was 1,400 individuals, females that were greater than 55 years, and they were randomized to calcium and placebo. And they were excluded individuals who had vitamin D less than 25. But when you looked at this population of individuals, he did do a good job in this group in looking at and trying to balance out individuals who were, in terms of risk factors, in terms of rates of diabetes, in terms of previous history of heart disease, and tried to look at that and do his best in adjusting for that. But if we look at the fundamentals of the study, there's a typo here, we'll talk about that. In terms of the previous history of hypertension, they're the same. It was 31% of the time. But when you go to the results, let me just move on. Okay, let me just go over this. So basically, they were looking at individuals with getting 1 gram of elemental calcium per day, and they were getting 200 milligram tablets. And there is a high non-compliance rate with calcium. You will see this. And then the cardiovascular events were assessed by adverse events that were recorded at every visit. So it was patient-driven data, and the frequency of the events were checked. But it was, again, patient-driven. And then what happened was, let me go right to the results. So here's the problem. Initially, it was potentially self-reported healthy postmenopausal women were self-reporting these things. So the number in the cardiovascular group was, cardiovascular was, as was shown here, higher in the calcium group versus the placebo group. Nothing else was really statistically significant. And then when you looked at the overall composite index at the end, where you see there was a statistically increased rates. But here's the problem. Let me go forward, then I'll go back. Is that, again, those were self-reported. Now we've gone to verified vascular events of self-reported healthy postmenopausal women. So this is the verified events by adjudications by different doctors, by different places. It changes. There is no increased rates of strokes. There is no increased rates of death. When you look at the composite endpoint, which is everything together, it is not statistically significant. And the MI is just barely statistically significant. And again, the change that has occurred was at the end of 18 months. When I spoke to other cardiologists, they were like, that's just simply not enough time to see a difference in a young population given a relatively young, low-risk population given this. So what happens is it the baseline characteristics or not? The other thing that was, we talked about this, the other thing that was interesting was the reason they did this study was that they were looking at lipid control with calcium. They were trying to see if the lipids actually help, if the calcium supplementation actually helped the lipids. And actually it did. It actually increased the ratio HDL to LDL, and it actually was beneficial. So again, there were significant problems with the study in that sense. And then I think that just basing a lot of your meta-analyses on your own studies has some problematic levels. So let's talk about other studies that have been done. One of the problems that has been done in studies is that overwhelming majority of trials are calcium and vitamin D, not vitamin D alone or not calcium alone. But there are well-respected studies from WHI, the Women's Health Initiative, which was very well followed, of 36,000 women. Now, not all of them took the medicine, not all of them followed up for the medicine. And what they had was very specific endpoints that they were looking at, which was cardiovascular death. And this was a very well-respected group of investigators. And what did those things show? So when you looked at individuals who were calcium and vitamin D versus placebo, there was no significant increase or change in terms of MIs. And in terms of stroke, there was a slight but not statistically significant decrease in stroke. This was the breakdown of this group. So in terms of looking at all different endpoints, cabbages, angina, and then other things like that, there was no significant statistical difference. But let's not stop in America. So let's go to other countries. So this was an English study, which was looking at calcium supplementation, cardiovascular mortality in older women. So as you may know, in England or the UK, they have a closed circuit medical system where they can track a lot of things that are unable to be tracked in the U.S. and can merge different data sets between prescriptions, medications, death, and all these other things. So, and they have a very large population here of 9,000 women, 60 to 89. They studied calcium and vitamin D from 2000 to 2005, and they did not have previous cardiovascular disease, stroke, or any of these items that occurred. And what they did was they followed these people for 2 years. They had to have at least 600 days of calcium supplementation, and that there were no increased risks for these, and what the results showed was there was no increased rates of MI, stroke, or death, and actually it was trending toward a beneficial number for these women. So basically the 2 years after initiation, women had consistently received supplementation of calcium and a very small amount of vitamin D. This was not that much vitamin D. They did not experience any cardiovascular events or death than women who received minimal or no supplementation. Then there was an excellent meta-analysis that was done in the Annals of Internal Medicine, a very well-respected journal in the U.S. that the majority of physicians very much respect. So they looked at a meta-analysis of vitamin D and calcium supplementations and reducing cardiovascular risk. They looked at multiple different data sets, and looking at that, they had a total of 17 different papers. And I'm sorry if this is a plot graph, and I didn't want to do this how they have it published. So they separated that into 3 different sections. One was vitamin D versus placebo, calcium versus placebo, and then the combination. Now the problem is that the vitamin D groups were fairly large total numbers of people, but in the calcium groups, the total number of events were not that high. But if we look at the vitamin D groups, there was a trend towards statistical benefit with the vitamin D, and I bet if they had one more study, they would have had clinical significance. If you look at the calcium-only group, there may have been a statistical trend toward worsening cardiovascular problems, but their confidence interval was fairly high. And when you look at the combination of calcium and vitamin D together, there was no difference. So their conclusion was evidence from a limited data set suggested vitamin D supplementations at a high to moderate dose, and I didn't like that term high dose, it's 1,000 international units, which is really not that high, may reduce CVD events, whereas calcium supplementation seemed to have very minimal cardiovascular effect, period. Further research is needed to elucidate the role of these supplementations in CVD risk. So what are our plans? So I'm working with Dr. Bassick on a new study, and what we're looking at is looking at the same data set and looking at calcium supplementation in coronary artery disease and assessing survival, MIs, and those major cardiovascular endpoints, and studying them in the same retrospective cohort that he has in the KU Medical Center. And again, we should stick to the scientific motto of the null hypothesis, where we feel that calcium supplementation is not associated with cardiovascular outcomes and survival, and the alternative hypothesis that it is. And then the second hypothesis is looking at the interaction between calcium and vitamin D and association with cardiovascular outcomes. There's 14,000 unique patients. We still have to look at the data and evaluate this, how many patients that we will have for this study. Here are the statistics, but I don't want to go into too much detail, except that we're going to be looking at it in multiple different statistical variants. So recently, this was just reported. I thought it was this week. I'm not even sure. Yeah, Tuesday it was shown. And unfortunately, I have a huge respect for the Institute of Medicine, but I'm just not sure where they got this data. What they said was that there was a limited number of studies that were randomized controlled trials, and that their target vitamin D level was 20. And that is not consistent with the majority of endocrine data that is out there. It's just simply not consistent with that. Most of our endocrine literature, which are large studies published by well-respected people and well-respected journals, was 30. So what occurred? So in terms of their recommendations, and really I have to focus on older adults, the 19 to 70 and older. And what they said that I guess when they say recommended daily analysis, is that minimum? I'm asking. I'm sorry. No. For this. Okay. So I'm assuming that's minimum, but again, this just doesn't make sense to me. Where they got the number of 600 when there was all of the studies that we have done is with 800 or 1,000 that have shown that. It's like We did all these studies, 800 to 1,000, and we got a number of 600. It doesn't make any sense. So thankfully, the American Association of Clinical Endocrinologists, this is what I was going to send to Adrian, was a very intelligent group and decided that they were going to publish their rebuttal statement at the same day. And the real reality is because they're clinical endocrinologists, and what happens is they realize that this can lead to a great deal of confusion in terms of patients, and a great deal of confusion in terms of primary care physicians, and a great deal of calls. So I think that these recommendations, if any of the RDs and others want to share with their patients, would be a very good start of the discussion, because the last thing that we want to do is to reduce vitamin D intake. It's like we've been working 30 years to increase vitamin D intake. So let's just reiterate. So the ILM report said that the vitamin D levels that they recommend is about 20 nanograms per milliliter is adequate for bone health, and it's not clear if higher levels are of benefit to other medical conditions, since most of the present studies were based on associations and not proof causality. Well, I think the Dr. Vasek's study, which of course was not in the ILM study because it's not published yet, does show some benefits in prevention of causality. But the question of this 20, I'm not sure where they got this. So thankfully, ACE has said that many physicians use 30 nanograms per milliliter as a minimum level of base on potential non-bone benefits and bone benefits. And we do agree with the upper limit of 50, but 30 is definitely something that we recommend. Second, vitamin D supplementations in the general population. IOM established the recommendations of 600 international units for this for the adult population, and not to exceed 4,000. Well, ACE stated, and this is what we do in our practice, this is what is done by Dr. Barbara Lukert, who's been doing this for 30 years, is that we recommend around 1,000 to 2,000 international units of vitamin D that's required to maintain a level of 30 nanograms, and that is well within the upper limit of 4,000 international units. So definitely 1 to 2,000 is very reasonable for these patients, but again, it should be determined individually by checking a vitamin D level in many patients. And the reality that was brought up by Dr. Vasek was that, majority of people are not getting enough sunlight, that they live in an altitude that is not consistent with a great deal of sunlight. And here's the interesting thing, is that, we as a society are getting less and less sunlight exposure compared to the past. So I'm not sure why 600 would even be a recommendation moving forward, because who knows when these guidelines and things will be revised. The other thing is that one place that they commonly do agree with is with the calcium recommendations. I think that in terms of the calcium recommendations, they're setting at 1,300 milligrams with a maximum upper limit of 3,000. And I think when you look at the 19 to 50 group, it's 1,000 to 2,500. And to be honest with you, the majority of my patients can't tolerate calcium that well. So going up too high is not worth doing it. And natural sources of dairy products are very reasonable. The other aspect for ACE that brought up is that the measurement of a 24-hour urine calcium is strongly considered to determine calcium balance in patients. We do this in our patients, but generally it's not recommended in a general population of people who don't have osteoporosis in other regards. But the bottom line is that at least that is common ground. I think that that's a very reasonable choice for individuals is 1,000 to 1,200 milligrams of calcium. You should break up the calcium into 2 different doses with meals, and that in the past, when I as younger, I would be strongly recommending calcium citrate because it has better absorption. As you get older and more experienced, you say whatever the patient can take, period. Whether it's chewable Tums, whether it's Flintstones, whether it's Viactive, whether it's a liquid calcium from a nature store, whatever that they could take safely is the right calcium for that patient. That's it.